even at the age of 60 with a post-bypass, this is a good case for TAVI. There's no doubt for surgery. My question is different. I want to hear regarding the operative steps you had. So you had a VT and VF and almost rest.
Can you put Ivor's slide on the screen, please?
And it was of course very daring, and you are not losing your cool, and you were doing still. You knew that if something is going to come back. My question is, in a post-dilatation also you had another similar episode. This amount of PVL, can we avoid post-dilatation in such cases where you have already had a almost cardiac arrest situation during time of dilatation?
Very relevant question. Should you be scared of a first outcome which has happened and it might happen again? You should know the reason. You should know the reason why this thing has happened. And if you know the reason, then it will not happen again. The reason it happened is the valve was there for a little longer time, the cardiac output was low, we had a prolonged pacing run.
Ejection fraction 40%?
Yes. Now let me come back to the point. That's why in the Euro PCR session, we showed that a mild paravalvular leak is also associated with more mortality at 7 years outcome. So if you can get rid of mild to trace and trivial safely without compromising mortality, you should treat that mild to moderate paravalvular leak.
I have an experience. The first case which was done by an Caribbean from India, that was November 2011. We took the patient from India, that was first from India. Apollo, in France. That was an inward safety and XT valve. We had a mild paravalvular leak about day 1 and we left it. And within 3 days, 4 days it was gone. So sometime during a follow-up it is gone. So is it really good? Is it really important to change this mild paravalvular leak or not?
In a young patient, we should, sir, 2011 to 2025, everything has changed. The valve has changed, the device has changed, the techniques have changed. But now we cannot leave mild paravalvular leak if you can treat it safely. So that's a caveat. You are not doing a post-dilatation with a calcified boulder at the LVOT and annulus.
I think the double tap method is also excellent rather than going with a high pressure oversized balloon.